Hey, we're live. Hey, everyone. Welcome back to another bright and shiny episode of the Coding Cheerleader Sessions. And I like shiny. But before we begin, a brief disclaimer. So, the images contained in this career will be graphic and not for depicting art. Please view records at your own discretion. And if you're eating, put it down. For those of you who decided to stick around after that disclaimer, the topic of discussion tonight is wound care. So let's rip off this band-aid and get into it. You like that? That was awful, wasn't it? Yeah. Mm-hmm. All right. So tonight we have two panelists. We have Elizabeth Herbert, who will be discussing her experience in wound care as a subject matter expert with the AAPC. And she's also, from what I understand, an epic person at Baptist Health. And then we have Voila Apostoli from AAPC Audit Services, who will be discussing the clinical aspect and supervisory aspect of wound care. She actually was the former director of coding for United Wound Healing. So, and there's me, who has seen some wound care in his daily travels in vascular surgery. Spoiler. So, Elizabeth and Voila, let's start with what wound care coding entails. What are some of the common conditions treated, and what are some of the common services performed in wound care?
Well, I can go first if you want. What I saw mostly with my wound care coding is a lot of diabetic ulcers, a lot of peripheral vascular disease patients. So a little bit of burns, a little bit of osteomyelitis, pressure ulcers, some radionecrosis from previous radiation treatment. Maybe see a gas gangrene occasionally. But I would say 95% was diabetics and peripheral vascular disease. And then for the actual services, a lot of it was debridements. We'd see some wound vacs, some skin grafts, hyperbaric oxygen therapy, and amputations sometimes when it got severe. So that's mainly what I would see.
How about you, Viola? Voila.
Ooh la la. Well, thank you for having us. And, this is a topic that does not get talked often. It seems like a lot of people are scared and stay away. And as you put the disclaimer, you would have to have the stomach to do this. But also it does take a special kind of a clinician to provide the services. As Elizabeth says, they provide and see a slew of things, not only the diabetic ulcers, those surgical ulcers, those amputation stumps that they do, those pyoderma gangrenosum, there's trauma wounds. It's not always the chronic wounds, and it all depends on the type of the center, the wound center that you are, because there may be a more, or where it's located, because you may have those areas where they're either understaffed, or the rural areas where your providers will be doing all and everything to make sure this patients are well taken care of. This limb, they're salvaging these limbs. They see, lymphedema. You wouldn't think that, lymphedema is something that a wound care provider will take care of it, but they do. And again, it depends where you are located. They will do those Una boots. They will do the wound vacs, the hyperbaric, the ultra mist. There's a lot, now there's a lot more attention going on wound care, because there's a lot of money being spent on these ulcers. And there's, even the CDC starting to do more research because they're finding that there are other, types of treatments, and it's something that, as the population is aging, the chances of getting a wound is much greater than, what we have seen previously. So it's getting more talked, and rightfully so. But you see a whole lot of things. You see the revascularizations. You see quite a bit. And if you are located at a practice, you'll know that either your wound care provider or your vascular clinic, um, by the fragrance when you walk through the hallway.
So it sounds like there's a lot to it. Like it had in my head, wound care. There's basically two codes. There's just your codes for your wound treatment and wound cleaning, and then you have your debridement. There's a lot more to it than that.
Mm-hmm.
So what kind of providers typically do this kind of work? Is this mainly just one type of taxonomy, or are there different groups that will do this? Do wound care, that is.
Again, it depends how it's set up. It depends. You can have a general surgeon. You could have a plastic surgeon that sees there's a need in the community, and then they're changing direction to do wound care. You can see a trauma surgeon providing. You can see a regular clinician. They're changing on orthopedics. That there's changing direction. So it all depends how the clinic is set up.
The providers that I worked with, I had vascular surgeon and podiatry. My podiatrist surgeon would also work at the wound care center that was located at our hospital. So they would work there maybe one day a week, and then they would see, they'd have their regular clinic as well, and their surgery room days, and they would kind of go back and forth. So but yeah, many specialties, and it really just depends on how it's set up. Like Viola said, if you have a facility that it specializes in burns, then you'll probably have more of that plastic surgeon and regular surgeons as well. If you don't have those burn units, then you'll probably see a lot less of them, because they're going to be transferred to a center or seen at a center that specializes in that most likely.
So it sounds like there's no escaping it. So any coder could stumble into one of these charts and really have to deal with it, because it seems like anybody can do these. Interesting.
Mm-hmm.
I mean, your primary care office can do some wound care. So be careful getting in those Epic charts. You might see a picture that you didn't expect to see.
Yeah, that's always lovely. Like right after lunch, you're just chilling in your cubicle eating your light Italian hoagie, and then you scroll down too quick, and there it is in bright purple, pink, green, and lavender color.
It's that much more tastier your lunch. That's all.
Mm-hmm. And you know what? You'll be tasting it again. Just this is the way that works.
No, I appreciate the pictures as a coder, because then I can see just how severe, what we're dealing with here. I can see, I'll see the measurements. I might be able to tell the location and verify that location with the code that was given. So I appreciate the pictures.
It helps you clinically too. Then you'll understand what Eshor is, what that, what an unstageable pressure ulcer looks like. What is that black stuff? What does it do? Why is this ulcer? Then you can see, and sometimes you can help the provider. And if the advantage of working in a clinic is that much more, especially if you're a new coder, I would say encourage to create that relationship, because you'll learn so much more on a whole lot of how to approach clinically, the etiology, the manifestation, the location, as Elizabeth said. So I appreciate the pictures as well. I'm not afraid of them.
I could do
So
without them. I honestly could do without the pictures. You just describe it to me in words. That is enough.
funny enough, I'll have all that. I need to see the picture because you know what? That picture is worth 1,000, words. And even with the greatest description, I would have to. Well, maybe it's just me. I always go and look at the picture, and especially if you're following, if you're working in a clinic, you're following this patient, that makes it that much more. You can see how either, the ulcer got worse or the wound got worse or got better by the treatment that, the providers did. And you can see, they're saying is, this much percentage, better or that much smaller. But you can see, I've seen wounds that are over 400 square centimeters, and in a matter of months, they go down to under 100. And it's amazing to see that progression. Yes, the words do it justice, but when you see the picture, it is that much more satisfying that, or seeing.
Well, that's not the word choice I would use. I wouldn't say satisfying. I would say necessary. That personal preference, just me. All right, so now we're going to get into some anatomy. So let's talk about some of the biggest issues with anatomy. And we already have a an audience member question related to anatomy. So we'll get into that as well. But what are some of the biggest issues with anatomy and coding that a wound care coder should take steps to prepare for, other than those super disgusting photos?
Well,
So,
I mean, you
ahead.
just gotta you gotta really know your laterality and location descriptions. When they're explaining where something's at, they might say lateral to, or on the dorsal aspect or whatever. So you've got to be able to picture that and be able to understand where they're talking about, and to make sure that you've got those correct codes, right? Because especially if we're talking ulcers, right? Because we've got a billion ulcer codes with location specified. And another thing that you'll want to have understanding of is your ulcer staging classifications, like Wagner. And I think there's typically I would see Wagner, but I think there's some other staging ones as well.
Like with
And
the what are those pressure ulcers are class 1 through 4, right?
right, so
And
you've
then
got your
stageable.
pressure ulcer and then your non-pressure ulcer staging. So being able to kind of understand what this, if it's a Wagner stage 3, then that means, muscle or whatever. I don't have them memorized. So, um,
So
but so you would know your depth as well, and you could verify that your code is also correct according to that documentation.
it is important because if you don't know the anatomy or even the the where location, because they could be, the provider may be talking about the ankle versus the thigh, where is it? There's two different codes, and then you go, upper, lower, could be the different areas, forefoot, midfoot, your toes, your ulcers. And sometimes they overlap, so you really got to pay attention to the description of where that is. And it is important, as Elizabeth said, to determine and distinguish between pressure and non-pressure. They may, call it a, diabetic heel ulcer, stage 3. It is not. Just because you see a stage 3, it is not the same code that you would use for that pressure ulcer. So distinguish. One way I try to remember and, keep them straight. And, if anyone asks, when we're looking at pressures, we're thinking stages. When we are looking at, chronic non-healing ulcers, then we're looking at severities. Even though that they call it stages based on Wagner on that, but those are severities, how deep they go. And, the provider need to tell us that. We cannot, If it's there, great, but we cannot, be the one determining it is this stage or it is this severity. And also be make sure when you are coding to verify, especially for those pressure ulcers, are you following, is your organization following the CMS guidelines for staging, or are they using the NPAP, the National Pressure Society? They have it slightly different. For the most part, the staging, aligns, but, one thing that comes to mind that is slightly different is the instageable ulcers. They have different qualifications. So ask those questions. What do we follow? What do we use for staging? Because it can make a difference, based on the documentation. Then you can go back to your provider and say, well, we follow this. Based on this would be this stage. So you also providing that education. You're not just coding, just creating again that relationship with the providers as well to get better documentation. In the long run, it'll pay. It'll make your life much easier when they start to learn what descriptions they need to use, what need to be included in that documentation.
Do you guys see an impact of these ulcer codes and these wound codes are kind of correlated with underlying causes, like, I don't know, diabetes or PAD or major
Yes.
major trauma?
Arthrosis, diabetes, sometimes, well, if they have the infection, the osteomyelitis, the PAD with the, diabetes, PVD. But even though with the underlying causes and the main culprit that comes to mind is the diabetes. Follow the indexing, because not every ulcer, just because the patient has diabetes, is automatically linked to that diabetes. Pay attention to where it is, because if it falls under that NEC, they meaning the provider, the clinician, will have to make that linkage statement. You cannot assume just the patient has a diabetes and they have an ankle ulcer that it is, related to diabetes. Only the foot ulcers, the heel, the toes, those are, is that, assumed cause and effect. Your pressure ulcers, those are due to pressure, even though it's in the heel. They never get coded. It's E11622. The provider would have to state that. It's amazing how many times, we see that happen. Follow the indexing. Those, the causes, they are pressure ulcers. Those are due to the pressure, not to the diabetes, unless the provider also says this is also, the patient also has this chronic ulcer and this. Otherwise, they're not linked together. So follow that indexing is crucial.
Yeah.
Is this related to the width a definition in the ICD-10 guidelines?
Correct.
So let's explain the width guidelines, because this is something that I talk about a lot, and people are like, "What are you talking about width?" So who wants to tackle that one? The width definition is different from other normal human use of the word width.
When you are coding and you are, let's say we're looking the, diabetes, the index goes diabetes, type 2, then you have width. Anything that falls under, the width, those are assumed conditions as due to the diabetes. But if something that's under the word width has that NEC, not otherwise classified, that is funny. It's included, but it's not. You will have to go a step further to see that the documentation, the provider is linking those two conditions, so they are related. The same applies to the due to or N. When we have, hypertension, then go, with CKD, the staging, those are assumed. The same thing with, you can either start with ulcer, location with, that's the longer way. If you start with diabetes type with, you get to the ulcers much quicker.
Anything you add to that?
Yeah, so the NEC, that was part of a coding clinic clarification,
Yes.
was it not? Yes. So that's a good reference to always have is your coding clinic. Make sure you've got access to those to get your correct coding down. But yes, and providers don't, they're not coders, so a lot of times they will just drop their individual conditions, right? They'll drop diabetes, then they drop their ulcer, and then they drop their PVD or whatever it may be. And so that leaves us coders to making sure that we're following those coding guidelines correctly, and that, we query or ask the provider when we have those types of scenarios where it would be an NEC, or, to get them to go ahead and link that in the documentation a little bit better when they say it is due to or in diabetes or whatever it may be. So
I would say, Elizabeth, Greg, is that knowing the coding clinic is a must. I would say especially for a wound coder, for those, there's the coding clinic that says, diabetes and, PVD, those are linked. You have to do the combination code. Finally, they came up with a coding clinic not long ago on how to code mucosal membrane pressure ulcers. We see typically when you lay down, but we forget about the tubing on on that O2, the oxygen tubes that the patient get, or the caths. They create those pressure ulcers in the areas where there's no staging because there's no bone, nothing to qualify. So look at those coding clinics because they do come very handy.
I always say that when coding clinics come out, or when the new NCCI manual comes out, whatever specialty you are in, you should go ahead and just go ahead and review the new info related to that specialty. So at least you've got, if you don't have time to, peruse it all, at least do your specialty. Yeah. And anytime you start a new one, then that's the time to go in and do some more digging, right? We always got to continually be educated as coders, right?
We never stop learning.
No.
So let's pose one of these. What do they call those? A hypothetical. Suppose a pregnant diabetic woman is being chased by a zombie in the middle of downtown New York City, and she's hit by a car. Yeah, could happen. All right. So in the hospital, she has open wounds from the zombie bite. She has a very traumatic injury, leg fracture. She's diabetic and pregnant. And discover that she also has arteriosclerosis from a plant. What gets preference to coding as the underlying source of that ulcer?
Is she carrying an alien?
Yes, she is.
Those are inquiring minds questions.
But does she also have HIV? Because that could also...
See, you've outdone me. There's actually a thing in the ICD-10 that says there's like a hierarchical classification. I think it's something to do with the case that they gave is during wartime, patient crosses the border and is hit by friendly fire during a hurricane. It's crazy.
I remember that.
But it's still in the ICD-10. They tell you what takes priority.
Your pregnancy codes will always take the priority.
Actually, the HIV.
Well, now that you threw that's right.
Sorry.
I was sticking to your example.
Yeah. So always check your guidelines because there's so many things that you'd have to consider. And I don't even know that any kind of coding scrub would catch that. That's something that you'd have to have some 4-dimensional coding list, like number 1, number 2, number 1A, 1B, because I don't know what would take preference or take priority. But that's how fun coding is. And I'm sure somewhere there will be a case, and I've just broken hip, but because somewhere out there's a person that was bitten by a zombie and ran away, hit by a car, and was pregnant and diabetic, and she's gonna say, "I'm suing you for privacy violation." Yes, and that would be the one thing that shuts this whole group down.
Now, you probably gave more detail in your hypothetical than we would see in an HPI.
Because there'll be
so
41 diagnoses
sometimes. So
your primary care officers, 41 diagnoses, PVD of them are 16 of them, diabetes are 14 of them, and way at the bottom is that they were in a car accident 37 years ago.
Right.
Well, I mean, technically, that's just for informational, so it can stay way in the bottom. we have to look at those code first, code others, use additional. So even when you think you know your ICD-10 back and front, you don't. And especially now that there's changes more than just in October. As Elizabeth said, we as coders have to live within these guidelines. We have to always reference back. Not every case is the same. Yes, we see the codes day in, day out, but not every scenario is the same. Not everything is presented the same way. Not every patient has the same comorbidities or the same things going on at the same time. But do review the guidelines, do review those coding clinics, do review the indexing. I mean, even a scratch codes to an abrasion. So see also, code this, follow the index, and it's not gonna let you astray, because many payers also, when they are coding, they're looking at the indexing, and if they cannot index it in the book, they will hold or deny that claim, because the code you have chosen may make perfect sense. However, the indexing, it is not taking them there.
Well, it's a good thing we only have 4 spots for diagnoses, then, isn't it? We can just leave a bunch of them off.
Oh no, it's expanded. There's more.
Well, and honestly, there could be scenarios where if we don't have a code first, type scenario, if they're being treated for an ulcer, we have arteriosclerosis with an ulcer. We also have diabetes with an ulcer. I mean, really, you could go either one as the first listed, and it would not be wrong. So, there are, and then that's when you come down to your provider, which one did he list first, or he or she list first, because that one's most likely, most of the time, they will put them in the order of, most important down to the least important. Occasionally they won't, but most of the time they put those most important ones at the top. So, and in that case, as long as there's no code first, anything like that, then I would go with that order.
All right. So we do have a question from the audience, and this is by a Mr. Marshan Martin. So the question is, he says he works in risk adjustment, and he wonders, what's the difference between an ulcer and a wound?
Many providers use those interchangeably. You have to read the entire note. They use them interchangeably, and typically they would refer to a wound, to an ulcer. They'll call it a wound at least 8 out of 10 times.
I've seen a lot of them. They will start out calling it a wound, then they'll call it a chronic wound. Sometimes they'll continue to call it a chronic wound. And, I think there might be some unwritten guidelines or rules where, once it's been there for 3 months, they call it possibly an ulcer. But I think that's unwritten, or maybe in one study they called it that. There's nothing out there definitive. So it's really what the provider
Yeah.
has decided to call it. So if there's been a wound for a really long time and we're talking about depth and things like that, then it might be the time to query them and say, hey, is this possibly, could this also
And
be?
there are some LCDs that say once a wound has not healed in a set amount of time, it has now become a ulcer.
Oh,
So
very
that's
true.
why they use it interchangeably, I believe, which doesn't make it easy, especially on risk coding. But and I know many wound sores and many wound society and providers, they do wound care. They're known. They would say that they would call an ulcer a wound. They
All right.
will refer, if they say heal wound. They're referring to an ulcer.
So
But
hypothetically,
again, doesn't make it easier on us as coders.
if I accidentally put my hand in the blender again, would I go to the provider and say, "Listen, I have an open hand ulcer"?
Well,
An
you will
ulcer.
go to the ED, I'm hoping.
Well, yeah, I mean that's what I'm talking about. Like as I'm trailing a bread, thing of breadcrumbs back from the Uber, which I would have to apologize to the Uber driver for the mess I left. But yeah, if I ever put my hand in the blender and I get an ulcer, using this definition, like, would that be something that like you can say, no, that's not an ulcer, that's a traumatic wound? Um,
Well, again, if they have a traumatic wound, in my experience, and I started with wound care, almost over 16 years ago. If there was a traumatic wound, almost always the word traumatic would follow wound. It was never just a wound, and they would say when it was, happened and everything, and continued. It would, the providers are diligent. If it is a traumatic wound, they will use those qualifiers. At least in my experience.
okay.
And a lot of ulcers really do start as some type of wound, or injury, especially in diabetics or people with circulatory problems,
Right.
is that, they scratch their leg or on something, or, they stub their toe or whatever it may be. And so it was just a little something at first, but because they have issues with circulatory, their circulation, then it never heals. That's where it develops into the ulcer. And it's just when the provider decides to say, okay, well, this is an ulcer.
Or when a patient comes in after stepping on a rusty nail and they come in and they complain out,
Well, they don't feel it until it's well infected, unfortunately.
All right, so we do have an add-on question. Somebody also posed a query in the same vein, no pun intended. Do providers use the term laceration and wound interchangeably? Now, laceration was something we just talked about not 35 minutes ago. So maybe this will jar your memory. Wound versus laceration.
I've never seen use those words interchangeably in my experience. Now, to say that it never happens, I wouldn't be able to say that. But with the providers and the practices I've worked with, if it was a laceration, they would call it a laceration. If they wanted to call it a ulcer, they would say now this has been reclassified as a non-healing wound, and from then on, then it would be called a wound or an ulcer. But they will make that transition.
Yeah, typically when I would see, if someone's presenting for some type of wound, the provider would give a description and, call it what they see. So a laceration, or, it would be more descriptive than just wound. I wouldn't see it really interchangeably there.
Yeah, keep in mind, we're actually talking about outer wounds. We're not talking about like things of your lower intestine. Like those kind of ulcers are
Right.
not wound care. Unless you purposely go in for a colonoscope to say, hey, check out this ulcer. I don't think that's what's treated historically in the same way. Let's see, what did we have? Another question on here, and I do apologize, but we're not getting all of the LinkedIn comments. I'm gonna see if there's any on the chat that didn't transfer over. I know I saw something come up from Dr. Who was that? Rosen. Sorry, Dr. Ken Rosenstock put something on the chat, and I saw it. Talk about or Ken Rosenstock mentioned something about can I raise with experts the different types, or raise the question with experts about the different types of debridement, for example, mechanical, autolytic, or enzymatic, because there's a lot of different debridement itself. And that always tripped me up. Like, what's the difference between debridements? Because that's multiple different situations too for code selection. But the question was, can we talk about the different types of debridement and what coding, like where they are in the coding book? Because they're kind of like bookends.
Mm-hmm.
Right. I'll let Viola give details since she's been in wound care longer than I have. But
Gee, thanks.
your excisional debridements in your integumentary system, and those are the 11,000 to 11,047.
Mm-hmm.
And then all your other types, your active wound care management, right? Your, like you were talking about, your mechanical and your enzymatic, and all those fall into your medicine section.
The 957, 975, one of those two.
I always mix them up when I'm looking at, just trying to pull them out of my memory, but it's the 975, 97.
975, 97, yep. And sometimes they use medications that will do that auto debridement, which is cool to read about.
And they use larvae too, which I've seen that.
Yes.
Yes.
It works.
They only eat the dead tissue, right? So it leaves all healthy
Yes.
tissue. So why not? I mean, sounds like it's great wound care.
And it's much cheaper than, they take them and they put them back on the jar and they do whatever and then they reuse them.
Wait, no. I don't want to hear that they reuse people that have eaten dead flesh. They eat dead flesh.
No, they just grow them in the jar and put them, whatever, and then take them back and then they're
that's like reusing the same needle. Yeah. I don't know. No, don't tell me that happens. No.
Hey, you had a zombie.
Yeah, but you can't blame the zombie.
No, I'll say you had that example, so I'm just trying to see, make sure everybody's awake and say, no, we cannot use that.
Listen, if I go in the doctor's office and I see his or her maggot treatment, I'm out. I'm sorry. No.
That's cool.
That's
actually pretty cool.
John P's maggots. Yep. And those are only for you, and you get them back next week.
It's actually pretty cool. With the debridement, as Elizabeth was saying, pay attention how many wounds are debrided. What is the depth of the wounds that they are debriding? Because it doesn't matter the location of the wound. What is important is the depth of the debridement. Is it to the subcutaneous tissue? Is it to the muscle? Is it to the bone? What is it? Then you add those wounds of the same depth together. That's how you can determine whether an add-on code is appropriate or not. But you cannot mix and match. You cannot add a sub-Q with a muscle. You cannot do a muscle with a bone or a muscle in that. Even though there may be in the heel, one, could be on the left, one can be on the right, but they're two different depths. So just, that is, if I could, leave you with anything, pay attention to that depth of the wound. And then, you can determine the add-on units.
I will say, because those two sections of codes were used 95% of the time or more within the wound center that I coded for, you also have to kind of remind yourself there is a section just for burns. There is a section just for pressure ulcers, because if those aren't the ones you're seeing a lot and you get one out of nowhere, you don't want to code from the wrong code set. Just because you're not doing them all the time and you just automatically go to that code set. And there's also nail debridements, if for some reason that falls in there with your specialist, or so just because you say debridement doesn't mean a certain code set. We got to make sure we're talking about the right type of tissue as well.
No, you're absolutely right, because the burn debridement, they have a total different code. They fall in the 1600, 16,000, sorry, section. And you have to know the percentage of the body surface area.
Yeah, there's a great table in the code book too that helps with that.
Mm-hmm.
All right, so I'm kind of grossed out. So let's stop with anatomy talk and let's talk about daily routine. So, with your experience in coding, like what was your day like when you would start your day? Like, you sit down and just start looking at gross picture after gross picture, or was there more of like an even spread of different stuff?
Again, it depends on where you are sitting. If you are doing nothing but wound care, it'll still be, are you doing a provider practice? Are you doing a facility? There could be facility charges. There could be professional charges, how they are divvied up. What are you doing? So it all depends what is, what is your setup like?
Back when I was coding wound care, like I said, I had some specialists that would go, once or twice a week to work at the wound care center. So it would be 1 or 2 days a week I would get charges that were for the wound care center. So mine, would kind of mix up. So some days I'd have wound care and I'd work through a big chunk of charges for wound care. Then other days I'd be doing procedures or, regular vascular clinic or whatever specialty, looking at those. So it was really, that kept it kind of interesting and not too, same every day kind of thing. The other things I would get would be, some of the wound care center that we had was, they would document on a separate system than what we had. So if there was any addendums or anything, then that whole chart came over again to be loaded into our system. It was an old legacy system, and then it moved to Epic. Of course, everybody moves to Epic, right?
Eventually.
But so I felt it was most helpful to have access to that other system that they used so that I could see the full chart versus the stand-in copied pages. That way I can make sure that the records were up to date and correct before, I submitted any claims. So yeah, it kept it interesting, not having to do the same thing over and over again, day to day. So that's my experience in it. But, if you code for a large wound care center, of course, that you're going to be doing that day in, day out.
Morning till night.
Lunch, after lunch.
All right, so we do have another question from the audience. This one is from Diana Ellis. We all know Diana Ellis. This is a good one. So can we clarify post-op wound care versus payable wound care? Where a patient goes back to the OR multiple times for, say, debridement of a wound or washout? Like, what are some situations where it's payable, sometimes where it's not?
Well, you'll have to know the payer and the codes they're billed. If they're billing the 11,000 series, you'll utilize the modifiers for going back and that, but they do not have global days. So if we're doing post-op care for those codes and no other services, then you will bill the regular E&M depending where you are seeing this patient. Is it seen at home? Is it seen in a nursing home? Is it seen at the practice? If I'm understanding I think that's it. All depends what those when they go back to the OR, what is the procedure that is being done to determine the post-op coding. Elizabeth?
And I think also, the typical wound management or, surgery site, care is included in your global days. But when you have something extensive or something that you have to go back to the OR for, then of course that is typically payable, but you do have to use your modifiers to show, this is a return, wasn't expected. Of course, if your original was, a major surgery 90-day global, then you've got, your modifiers to also append to that.
Now, is there some also issue or statement made in the global package manual or the Medicare uh, Medicare Learn Network had a published document called the Global Services Manual, and they mentioned something about that doesn't relate to burns, or there's some odd exception related to burning. People that have like long-term burns. Is that?
I think I can't say for certain, but I think I've read what you're talking about, and for me to just pull that out of my head, I would have to, I'd have to do my research. But yes, I think there are, there's definitely some resources out there.
Yeah.
I think the MLN or like the claims processing manual, something like that. Both of those would be good things to look at.
And they recently also updated the surgical booklet finally, because it was out for quite a bit. But they still say, and that's why I said, you have to know your payers, because CMS, any complications, it's part of that global, if the original service had global days. So it would be part of that, would be built up as that post-op code, the 99024, when you're doing the post-op. I know other procedures are done. So you'll have to know those, you'll have to read up and know your payer. Because commercials have different, when it comes to complications and that, and CMS has different guidelines.
All right, so let's go on to my question, because we've been doing a lot more technical stuff than we're typically doing in these sessions. So let's go on to some actual job-related stuff. So, what are some skills or tools that you feel are important in your daily role, other than a strong reflex? Because that's also like number one on my list.
Attention to detail is definitely one. Ability, communication and education skills. So being able to confidently, talk with providers and educate them, but also, receive education yourself, and be able to communicate, professionally. That goes a really long way, especially in something like wound care, where you can have some differencing of opinion or some gray area depending on the documentation. And so it really makes a difference when you can communicate with them and, come to a consensus, moving forward.
Most definitely. Ability to research is another. To know where can you find resources. What would be a good resource, and what would be something that's just informational. that goes along, the way. Um, know your policies where you are working. If you're working in, skilled nursing, learn all about it. What's included, what's not. Know about those consolidated billing. Not, just because you may have worked in an office and you could bill those, what was it, 597 codes. You cannot do that in a nursing home. If you're providing services in a home, does your patient have a home health? Because again, you need to know those guidelines. What can go to the payer and what needs to go to the home health, or vice versa. So research is a lot, especially if you're working on a nursing facility. They have a lot of guidelines that the providers will also have to abide by, that sometimes the clinical and the coding does not correlate. So as Elizabeth said, you have to be very skillful when you're talking and educating your providers, because you want them to document so that the criteria for the nursing facility is met, because they have surveyors, they have policies, they have all these guidelines. But we also want to ensure that the coding aspect of it is covered by the documentation. So being open to that communication, then you'll have providers that are more receptive to hear and listen to what you are bringing to them, and your concerns.
Is there a lot of math? Because like I failed
Yes.
geometry, and if I have to calculate 3 pi r squared over exclamation point, I'm gonna have
Yes.
to pass off to someone else.
If you're doing the Friedman, yes.
Hard math, or is it like things I can count on my fingertips?
Well, it'll depend how big the wound is, and if you have providers that like to document their wound in inches, you gotta change it to square centimeters. And if they do it in millimeters, you have to change it to centimeters, and then do the rest of your math.
Now,
It's not a lot.
now your friend Google is really good at converting for you if you haven't learned that in your previous math classes. So Google can help you with your math.
That's good.
Just
And
don't
if you know the metric system, it's a breeze.
Yeah, there would be times where I would see inches documented, and I
Or
would have
millimeters.
Mm-hmm.
Yeah.
Yep.
Like I would probably be the kind of
But it's
person who's like, my doctor documents like 0.001 kilometers.
He may go to a meter before he go to a kilometer. Math is fun.
Math is not fun, not in coding. No, that's what slows the process.
It's all numbers, right?
Yeah,
We had numbers. We used to have ICD-9.
Yeah. All right, so Venus is a very technical based process, and a lot more than I thought it was. Once coders master these foundations in wound care coding and claim submission, what's the next step they can expect? Like, how do they progress? And is there any progression to like the higher level? Like, is there like a wound care coder too, or is there like other levels of wound care coding?
I would say that you could expand to your specialty specific topics. So, like I said, I had vascular and podiatry as, the providers that went to my wound care. So, picking up their other type of procedures. So whether it be the podiatry procedures or your, catheter-based vascular treatments, or some of their, open bypass, or, amputations, those could be your next steps in, expanding on, the procedures that your provider may also do. And a lot of those, advanced procedures are going to be on patients that they will also end up, treating ulcers for, later on down the road as well. So you're going to see those other procedures hand in hand for some of these patients.
Education is another step too, to move into, and if you're not having that multi-specialty, that's something to look into. Um, every organization, no matter how small or big it is, they all need educators. They all need um, so that's something that could lead to.
Okay. So if anybody's interested in wound care, what are some places that you would recommend that they start learning? Where can they find out more information about how to code wound care?
CMS has several webinars, different MACs. Learn about, the OASIS that has a lot, that CMS has on the wound care, and that goes with the nursing facilities. The impact, NPAUP. They have good resources. Wound Source, I believe it is. They have good references, bring up the latest, and especially they talk about grafting and things of that. Payers sometimes have it too. So it's just a matter of you keep on searching until you find, and once you find one, you'll see the rest of the links, and but CMS does have some resources and webinars.
Yeah, payers, especially with the diagnoses, risk adjustment, such, they do topics on, diabetes and ulcers and such like that. So that's a good one. I had one just a second ago. Left my mind. AAPC webinars.
Are there any organizations that are good to go to as well? Like, I don't know, the American Dermatological Wound Care Treatment Maggot Association. I don't know. But, I'm sure there's somebody that has a niche education related to like larva care.
Well, some manufacturers, they also do webinars. So you might have a manufacturer of some type of skin graft material that might do some kind of education on the coding of that. So,
All right, I'm glad you took it that, because I was first thing when you said manufacturers, I was thinking they make robotic larvae now.
No, but they make fish skins.
Yeah, somebody did make a comment about that's what I think was gross too. You go out on the boardwalk in New Jersey and you can pay someone to let you put your foot in a tank and fish will eat dead skin off your foot. Gnarly.
Oh yeah, they have those this Asian spas and things. So yeah. I'm terrified of that. But National Pressure Ulcer Advisory Panel. Okay. That's where I find quite a bit of information as well. But again, be mindful, if your organization is using the staging, especially that the CMS has defined, do not go by the National Pressure Ulcer Advisory Panel. Because there's, for the most part, they align quite well, but there's some differences.
Okay. Any last minute comments or any questions? I know we went through a lot of the chat for questions, and I think we covered a majority of them. I think there was one I wanted to bring up by my friend Barbara about the difference between or what the prevalence is of different kinds of ulcers, pressure ulcer versus non-pressure or non-stageable.
I don't know about the prevalence, but it's definitely better to have the non-stageable versus like an unspecified, right? But because those stages can be pulled from non-clinician records, and you can pull that from like the wound care documentation, the wound nurses documentation to get that specificity, I would think most times you're going to have some type of stage. Um, typically you'll have a stage, but there are times where it is non-stageable. But to have unspecified nowadays is probably a lot, more rare than it was.
Well, and I'm glad that, CMS finally made that change in the guidelines where the clinicians, because they do a lot of that, measurement, and they do a lot of that evaluation. And an ulcer, a pressure ulcer, may start as a non-stageable because they cannot see until they move that eschar, that black, area in there. Or it has started as a hematoma where it hasn't broken the skin yet, so they can't really see, but through, and it may need a debridement. So with that, I would say we didn't touch on that. It's very important when you do a debridement to look at your documentation, and also educate your providers that if there is a change in the stage, that they need to document that. An ulcer can go from a stage 3 to a 4 or 2 to a 3, but you will never backstage a pressure ulcer. Once that skin is broken, the integrity of that skin, it's never going to go back to where it once was. And also, if your provider's working in the skilled nursing facility, one of their guidelines is they cannot backstage an ulcer. So a provider may say this is a healing stage 3 ulcer, but it will remain that stage 3. It's not going to go to a 2. It's not going to go to a 1 and then it's going to remain that stage 3 unless it changes, it gets worse, and then goes to that stage, that next stage. So it's important to, do that education, and, those details, are important. And also, if we know what the patient came with, what stage, we're going to document both stages. We're going to report both stages in that claim form. What the patient, the present on admission, and if the ulcer progressed any further.
I will say that working denials as a coder was very beneficial and helpful to me to understand and learn all those different payer guidelines and policies. And so never take, always take advantage of that, and don't think that doing your AR or billing side of coding is not beneficial and not part of coding, because it definitely helps you to understand, when you've got MUE limits, like what can you do for Medicare? You can do your Medicare redeterminations, or if you've got home health patients and they see an APRN versus a physician, why didn't you pay this one, but you paid this one? So you definitely learn a lot and improve your coding when you see those claims on the back end.
More, yeah. You couldn't have said it any better. It makes you that much better. Yeah.
All right. So, any closing words of advice for potential wound care coders out there?
Despite your warning, it is a great field. It exposes you. It seems like there is not many codes, but there is a lot to learn. As Elizabeth said, there is a lot to learn. Do not be afraid to ask the questions. You'll be surprised how many providers are eager to teach. Mm-hmm. They'll love learning about coding, but they'll teach you, and ask questions. Look, if all you're doing is coding, you have downtime, look at the denials and see why. That's how you get to learn. Well, look at the MUEs, look at the MAIs. What's the difference? What can we do with different MAIs? What some of those things, because that you bring even more to the table, to your organization, to your practice. You become that more valuable. It is. I know John doesn't like it, when I use the word satisfying, but when you see, the provider, it takes a special kind of provider to work in wound care. In all my years of that I've been doing this, it takes a special kind. They are very compassionate. They will go to no they have no limits when it comes to helping their patients. They will go out of their way and they will drive for 3 hours if it means to go and take care of that patient. And to see that and to see all of their efforts and all, what you're doing, and to see how these wounds are healed or how many, limbs have been, saved, it is satisfying. It is a rewarding field to be in. So don't be afraid. Give it a try.
Yeah. And try this. Go next time you're on your off day. Well, wander into the ER and say, "Hey, before you close it up, can I see?"
You know what? It's funny. When I first started, when I first started, our provider used to bring the charges, and we're talking, and I'm like, Dr. Jones, I see you're doing, all this Wuna boots. Well, what are they? What they look like? I'm thinking it's like the DME, the walking boot. He goes, I'm not going to tell you. You're going to come and see, the practice. I'm like, no, just tell me. He's like, no, tomorrow I'll see you at the practice. Little did I know, it is not a boot. It's a rabbit. It's like a machete. It's like a paper. And he could do those so efficiently and so quick. You'll be amazed to see. So, yeah, I agree with John. Go and see.
Yeah, I'm personally
Be curious.
Patient Ebola day. Nope.
Yes, I feel like always take the opportunity to learn anything on the clinical side, because obviously if you take that step to learn from them, then they're more likely to listen to you when you have something to talk about, and offer as a suggestion to their documentation or their coding. So.
And you can say, hey, what do you mean by this? I don't, help me understand it. Where I see it many different ways. What are you saying? Or what is going on here? They'll stop in a heartbeat and explain. Now, don't go to them and say, well, you did this wrong.
Yes.
Nobody's
I guess in this case, the most, I want to say, in regards to documentation, I guess the more the better. But when they start talking about how it tastes, you kind of have to draw a line somewhere. So dimensions, look, color, I guess they're all important. But you just gotta make sure that don't think too much into it. Unless you're the kind of person who likes to watch the TV show Dr. Pebble Popper. We got one. All right.
That's me.
Well, I'd like to thank our panelists today, Voila Apostoli, Francis, and Elizabeth Hurley. And if you have any questions, they're on LinkedIn. You can ask them all the gory stuff. I'm sure they'll love to tell you stories about it. Not me. Ask me about words. But again, thank you. And we're going to take a little break for a couple weeks, but I am thinking of doing episodes on pulmonary neurology, and I think we have one on the works for revenue integrity. Those are some of the ones coming up, but it's going to be a couple of weeks. We're going to take a little bit of a break until after the first week of July. We'll get back in the swing of things. I have to organize some more people to agree to talk to us. But if you have anybody that does any pulmonary, any neurology, neurosurgery, or any kind of revenue integrity, have them reach out to me. All right.
Thank you. I'm
Thank
sure especially our new coders appreciate the sessions that you do. So thank you.
All right. Good night, everybody.
Night.
All right. We're no longer live, or maybe we are. I don't know.
Are we?
We could still